keynote speaker. So Shweta knows that. So I was trained under a pediatrician at Tata Memorial Hospital and the legendary oncologist, we can say, Dr. Purna Kurkure. So childhood cancer. So let me set, there's a context for today's.
Sir, please go to full screen mode, sir. Full screen mode, sir, please.
So the theme for 2021 to 2023 International Childhood Cancer Day is a global collaborative campaign to raise awareness about childhood cancers and to express support for children and adolescents with cancers, the survivors and their families. So better survival is achievable through your hands, right care at the right time by the right team.
Excuse me, doctor, my apologies.
Yeah,
you're on the presentation mode. Would you like me to share to share your PPT instead?
Yeah, please go ahead.
Okay, one moment, please.
Right. Go to the next slide. Yeah, so the better survival is achievable through your hands, right care at the right time by the right team. Next. So cancer is a global problem. We understand that in spite of all advancement, including all adults and pediatrics, we are losing 10 million cancer patients every year. So 80% of the childhood cancer cases are in the lower and the middle income countries. If you look at the whole world, so 300,000 childhood cancers are diagnosed every year. So even in India, so almost 500,000 childhood cancers are detected every year. A large percentage comes to us in an advanced stage. Next. So what are the gaps? So last week only we celebrated the World Cancer Day, 4th of February. So the theme being close the gap, and if everybody will agree that so the gap is much more is seen in the pediatric cancer patients. So if you look at the developed world, 80% would survive if we're talking about broadly about the pediatric cancers, whereas in developing countries, so that is not true. Next. So still many parts of our country, many parts of our state, you will see there is a belief in the government and people resort to an alternative medicines even in a curative setting. Next. So late presentation is there. So there is a lot of lack of awareness. Patients are unable to reach the tertiary center. So that can be one of those reasons that patients doesn't come to us. So still there is a lot of gap. Next. So inadequate resources. So thankful to the state governments and the central government, they have come with so many schemes. So the situation is definitely improving. Otherwise, inadequate resources is one of those which creates a gap in the cancer treatment. Next. So childhood cancers, unlike the adult cancers, so still we don't know in the majority of the cases. So what is the cause of this cancer? Next. So are you going to prevent it? Is there any way? Because we don't know the risk factor. We don't know the that it is a lifestyle changes. So there were no screening tests as compared to what we do in the adult cancers, like in breast cancer, cervical cancer, and oral cancers, and in the colorectal cancers. Next. So we go by the World Cancer Day theme, close the care gap. So everyone deserves access to cancer care. So why not the pediatrics, those innocent kids? We need to close the care gap, which became more evident in COVID times. So this gap can be related to diagnosis, treatment, compliance, and access to the facility where the cancer treatment is being there. So neither finances nor distance should pose barrier So once we are discussing treatment of any kids. Next. So race doesn't define you. So why should it deny you? So where you live should not determine if you live. Next. So just to end, before we go to the keynote speakers, so pediatric malignancies are highly curable. Appropriate screening investigation is to be done at the earliest. So complete histological diagnosis and staging evaluation is mandatory if you are talking about solid tumors. Early referral to a pediatric oncology center optimizes. So now there are super specialization in pediatric oncology. So at least in my city, so there are already 3 pediatric hemato-oncologists who are doing a phenomenal job. Next. So in this COVID time, we need to restore the balance for cancer care in the COVID-19 era. So I am aware, so because I am a caregiver, so unite and care and do it for the kids. Thank you, ladies and gentlemen, for patient hearing. Over to you, Jojo.
Thank you so much, Doctor, for that informative presentation. Now I would like to welcome Mrs. Neha Sarah, Faculty in Nursing, Department of Psychiatric Nursing, RV College of Nursing, Bengaluru, Karnataka, India, who would be welcoming this gathering today. Hello, ma'am. Good afternoon.
Good afternoon. A very good afternoon to one and all. This day is an opportunity to raise awareness about childhood cancer, to express support for children and adolescents suffering with cancer. At the forefront, I could like to welcome our today's resource person, Dr. Shweta Bansal, consultant pediatric hemato-oncologist and BMT physician at Sri HN Reliance Foundation Hospital and Research Center, Mumbai. And ma'am is also a joint treasurer and executive member of PHO, chapter of Indian Academy of Pediatric. Ma'am have received a lot of award for best research paper at national and international conference. Ma'am is here with us today to address on changing paradigms in treatment of childhood cancer. On behalf of RV College of Nursing and International Association of Oncology, I wholeheartedly welcome you, ma'am. Next, it is my honor to welcome our second eminent speaker for the day, Dr. Stanley Prakash, consultant pediatric hemato-oncologist and BMT physician at Aster CMI Hospital, Bangalore. Sir is a member of Indian Academy of Pediatric Hemato-Oncology chapter of IAP, European Society for Bone Marrow Transplant, American Society of Hematology, and has a fellowship in Royal College in Pediatric and Child Health. Sir has numerous publications in national and international journal. Sir is with us today to address on childhood cancer and role of nurse. Welcome you, sir. A leader is one who lights the path to impossible, and a leader is one who lights the paths to the impossible and takes those who follow to a great height. It is my great pleasure to welcome our respected principal, Dr. S.R. Gajendra Singh, sir, for his constant support and encouragement in organizing this webinar. Welcome you, sir. Next, it is my pleasure and privilege to welcome the entire team of International Association of Oncology for collaborating and working together with us for this webinar. Next, I would like to acknowledge my heartful welcome to all the HODs and faculties of RV College of Nursing. Welcome you all. We would like to extend a special welcome to all the delegates, nursing faculties, students from various institutions. Thank you so much for honoring our invitation and gracing this occasion. Your presence makes us very happy. Hope the session will be a fruitful one. Have a great day.
Thank you so much, Mrs. Sarah. And thank you also for introducing our respected principal. And now I would like to welcome Dr. S.R. Gajendra Singh, the principal, RV College of Nursing, Bengaluru, Karnataka, India, who would be delivering the inaugural address. Sir, good afternoon. Welcome.
Thank you. Namaste. Good afternoon, everybody. Today's esteemed and efficient resource persons for this webinar on International Childhood Cancer Day, Dr. Shweta Bansal, Consultant Pediatric Hemato Oncologist and Bone Marrow Transplant Physician, as well as Dr. Stanley Prakash, Consultant Pediatric Hemato Oncologist and Bone Marrow Transplant Physician of our Aster CMA Hospital, Bangalore, my dear nursing faculty, my dear nursing students and delegates. I wholeheartedly welcome you all for this scientific webinar. Every year, February 15 is observed as the International Childhood Cancer Day in a collaborative campaign to raise the awareness about childhood cancer and to express support for children and adolescent sufferings with cancer. More than 4 lakh children and adolescents below the age of 20 years are diagnosed with cancer every year in the world, while the chances of their survival are close to 80% in some high-income countries. The rate of survival for such patients from low-income countries is as low as 20%. That is when Childhood Cancer Institutions observed that the first International Childhood Cancer Day in the year 2002 to make the finest medical and psychological treatment available to these children suffering from cancer, regardless of the limitations of their location, ethnicity, and social background. This year, the theme is Better Survival is Achievable Through Your Hands, with focus on paying tribute to medical team and healthcare workers and the positive impact they have on the lives of children and adolescents with cancer and vice versa. As we are all health professionals, it is our responsibility to join hands together for better survival of children and adolescents suffering with cancer. On this occasion, I am very much indebted and thankful to our honored and esteemed resource persons for today's webinar, Dr. Shweta Bansal and Dr. Stalin Prakash. I thank you for both of you wholeheartedly on behalf of RV College of Nursing for accepting our invitation, for sharing your knowledge on this platform, especially relevant to burning issues related to childhood cancer. And also I extend my heartfelt thanks for all bearers of organizing committee for this webinar. So dear participants and delegates, I hope you will be having good takeaways of this webinar and kindly participate actively and take advantage of today's scientific session. Thank you. Jai Hind.
Thank you so much, Doctor, for sharing your time with us. Thank you so much. Now I would like to welcome our first keynote speaker, Dr. Shweta Bansal. She is currently working as a consultant pediatric Hemato oncologist in Sir H.N. Reliance Foundation Hospital and Research Center in Mumbai, Maharashtra, India. Doctor, good afternoon. Welcome.
Thank you, Jojo. It's an honor and privilege to be here. I'm really honored that International Association of Oncology has initiated this webinar with RV College of Nursing and invited me as a keynote speaker. I hope that I'll do justice to the whole invitation and would make an impact on the presentation. So can I share my screen?
I will share it there.
I'm sharing, sorry. Yeah, thank you. This is yours?
Yes.
Okay. You have shared it?
Yep.
Okay. Okay, 1 minute. So first of all, I would like to thank Dr. Ghamsham Vishwas sir. He was my super senior in Tata Memorial Hospital. And when I entered, by that time he had already left, but I heard from my other seniors a lot of stories about him, and he's always been an inspiration to us. And he's doing a fantastic work in Orissa, Bhubaneswar, in the field of oncology. And thanks to everyone with RV, associated with RV College of Nursing, for inviting me over here for the webinar. So as introduced by the speakers, today we are over here to celebrate this International Childhood Cancer Day. And the theme of this Childhood Cancer Day is through your hands. That means the participation of healthcare workers to improve the childhood cancer survival rates all over the world, especially in low middle income countries. So today I'm going to speak about the changing paradigms in childhood cancer from incurable to curable. As we know, today we are talking about childhood cancer, but few years back, nobody knew that the childhood cancer is there, it happens in the children, and many of the times it went unnoticed, and many of the children, they had to lose their life because there was no awareness about it. But now we know that childhood cancer do happen, and it is our duty and it is our responsibility to increase the awareness as much as possible, because we now know the cure is possible and we can treat these children. So most importantly, the burden of cancer, we know Indian population is huge population, and it is about 18% of the whole world. And in India, 30% of the population is from 0 to 14 years, which is around 38 crores, which is almost equivalent to a USA population. So that's a huge population of young children and adolescents we have. And overall incidence of childhood cancer is 38 to 124 patients per million per year, which means that around 15 to 75,000 new cases per year happen in India, and in worldwide it is around 400,000. So approximately in India, 100 new cases every day happen. Next slide. So what are the type of childhood cancers which happen in children? So foremost, it is very, very important to understand that childhood cancers are much different from the adult cancers. Childhood cancers happen in the areas which are fast growing areas, like our brains, our lymph nodes, our immune systems, our abdomen, our blood, and all these things. They don't happen like in adults, which we see like lung cancer, throat cancers, or breast cancer, or cervical cancers. They don't happen in the organs. So the acute leukemia, CNS tumors, lymphomas take the major precedence, and the most common childhood cancers. These are followed by the soft tissue sarcomas and Venous tumors and neuroblastoma. And then there are eye cancers like retinoblastoma and other rare tumors are there. So majority of the 50% of the cancers are mainly blood cancers, CNS tumors, and lymphomas. Next slide. So in this graph, you can see there is a particular incidence as per the age. Many patients, many parents, or and a common belief is there in the society is that the cancer doesn't happen in children, but it does happen, and very small children also gets afflicted by it. We see more common kind of cancers less than 5 years of age, then there is a dip, and then there are more cancers in the adolescent age group. So the cancers which happen, next slide. So the cancers which happen in early age, like up to 5 years, are mainly embryonal kind of tumors like neuroblastoma, Venous tumor, retinoblastoma, or primitive neuroectodermal tumors, or then followed by acute leukemias, which are blood cancer, lymphomas, gliomas. And while in adolescence, we see more of sarcomas like osteosarcoma, Ewing sarcoma, soft tissue sarcoma, because they have rapid growing bones. So that's where the bone tumors and the sarcomas are more commonly seen in them. Then we see Hodgkin's disease and testicular and ovarian cancers in that age group. Next slide. So now the question arises with this knowledge, like we now know that the childhood cancer happens, and there are particular cancers which are quite common in children. But is the childhood cancer curable? And is it worth employing resources for children suffering from cancer? Because a country like ours, which is a low middle income countries and is having a resource limitations, many times other causes of childhood sufferings take precedence, like malnutrition, infectious diseases, tuberculosis, etc. But there is always a question whether it is worth employing our resources to save the children who are suffering from the cancer, because many times the people think that the cancer cannot be cured. So next slide. So this graph actually clearly shows us that over the decades, when the cure rates of childhood cancer was less than 50%, has risen to almost 80%. It means that it is worth saving these children, because if a proper treatment to these children is given, they can survive. And definitely they deserve a life. And that is our responsibility to give them a chance to live by giving a proper treatment and providing them the facility for the treatment. Next slide. Similarly, if you see in adolescent and young adults also, the survival is improving. Now, the 5-year relative survival is almost 85%, which is from the SEER data. Next slide. So what is considered as universally fatal diagnosis in 1950s? In 1960s, there were certain attempts on the treatment of these cancers like Hodgkin's lymphoma, Venous tumor, and sarcomas. They were started getting treated with surgery or radiation. But still there was a high recurrence rate and there was death because of these cancers. Then in 1970s, the multi-agent chemotherapy era occurred, and Hodgkin's lymphoma is the poster boy for that. And from there, the people understood the need of multi-agent chemotherapy, and they started successfully treating cancer patients. And this was the first time then they realized that if they are treated properly, these cancers can be treated. As Dr. Vishwas mentioned that we have learned our oncology from stalwarts in Tata Memorial Hospital. And I still remember one message from Dr. Banavli, who was the head of the department in pediatric oncology. He always used to tell us that most of the diseases are treatable. But the diseases which we cannot treat, it means that we don't know how to treat them. And as we are improving our knowledge, and as we are improving our knowledge about the pathophysiology of these cancers, our treatments are improving, and that's why we are able to treat many children. And based on this, I would say, based on this understanding, we are able to give risk-directed therapy to these patients, and this has improved the outcomes tremendously. And now the further refining of the therapy is based on the genetic advances also. So based on the genetic mutations, we know which targeted therapy should be given to these patients. So all these things we are coming to know that cancer is not a homogeneous disease. One thing. Second is cancer is all the B cell or the T cells or the leukemias which we treat, they are not same. Even the B cell is not same. Even the T cell is not same. Even the Hodgkin's lymphoma, once we get the diagnosis, is not same. So this has led to us more personalized and targeted based therapies, leading to a least side effects and definitely the better cure rates. Next slide. So this is one of the graph which I always like and is always inspired that one day we also have to reach to this place. And you can see it is from St. Jude's Children's Hospital, which is one of the best hospitals in the world and achieving great results in the treatment of childhood cancer. And they show that now if we do a protocol-based treatment in a disease like acute lymphoblastic leukemia, we can reach almost near to 100%, which is not possible in many of the infectious diseases in low middle income countries also. So this is like something which is unthinkable at this point, maybe in low middle income countries, but it is achievable if we do a collaborative effort on this front. Next slide. So, so these are the acute leukemia results from the different groups, and every group is able to achieve result more than 80%. So this phenomena is not restricted to one hospital or to one country, but across the globe, we are able to achieve this now. Next. Similarly, with the Hodgkin's lymphoma, there is a tremendous improvement in the survival. In 1960s, the survival was almost 30 to 40%, but gradually improved with the multi-agent chemotherapy, then followed by a judicious use of radiation therapy. Then we had more of a targeted therapies. And now in 21st century, we are talking about 90% survival in this kind of a disease. Next. Similarly, with the acute myeloid leukemia, which is one of the fatal disease, the survival is improving with the changing in the protocols and improvement in the protocols. Next. So now the question is, what has made this possible? Maybe with you must be having some idea like how we are able to achieve this better results in the childhood cancer. Next slide. So there are many things. There are neuro advances and there are learning from our mistakes. So foremost important, which is very, very relevant for our lower middle income and resource limit settings, is better diagnosis. So correct and rapid diagnosis is very, very important for embarking on a proper treatment. Then better personalized therapy, risk categorization again is very, very important. This is to give the optimal treatment and also to prevent over-treatment, to prevent the late side effects, because we know that the late side effects lead to later adult life morbidity and mortality. Then better monitoring is very, very important now. We are able to monitor the effectiveness of the treatment. So it's not just the protocol-based treatment. We can improve our protocol-based treatment depending upon how the childhood cancer is behaving with the treatment. If there is a slow response, we can increase the treatment. And if there is a very good response, maybe we can cut down the treatment. And this monitoring now is available at many centers and easily available at many of the cancer care facilities. We can do it by minimal residual disease, that is flow cytometry. We can do PET CT scan, and there are tumor biomarkers. Then ultimately, there are better treatments. By more effective treatments, we are talking about CAR T cell therapy, we are talking about immunotherapies, and there are targeted therapies. And foremost is best supportive care. Without good nursing, everything else is not useless, I would say. So nursing training, specialized courses in oncology care are the foremost in improving the treatment in childhood cancer. Next slide. Next slide. So there is a journey from FAB classification to immunophenotype to molecular classification. I would say just 2 decades back, when the child used to come to the OPD, we used to label this child whether he is having an acute lymphoblastic leukemia or acute myeloid leukemia based upon the pathological picture under the microscope. So we used to treat these patients just like one homogeneous disease. But now it is no more this kind of a thing, because we know that though the cells look similar under the microscope, but there are huge differences. There are genetic differences, there are molecular differences, and because of that, the outcomes are also different. One child who is having a diagnosis of B-cell ALL, he lives long with the minimal treatment. And one child who is having a similar diagnosis of B-cell ALL, even with the heaviest treatment, even with the most aggressive treatment, is not able to live and relapse. So why this is so? So now we know that there are certain molecular changes, and molecular classification is important to treat with the personalized therapy so that we can cure the most difficult cases as well. Next slide. So as I said, like acute leukemia, lymphoblastic leukemia itself is not a homogeneous disease. It is based upon the immunophenotype, molecular workup, genetic aberrations. Even the T cell, when we used to think that the T cell is a high-risk disease, but now we know that not all T cells are high-risk. There is a certain entity called early T cell precursor ALL, which is actually a high-risk and cannot be treated without transplant. Similarly, B-cell ALL, all B-cell ALL are not low, standard, or intermediate risk. Some of them are very, very high risk, depending upon the ECROS and CRLF2 mutations. Similarly, in the AML, acute myeloid leukemia, we have APML, we have FLT3 mutations, which actually define the course of the disease. Brain tumors, histopathological diagnosis is very important. Medulloblastoma is not one diagnosis. We have 4 types of medulloblastoma, and it depends upon those types whether they are standard or high risk. So hence molecular workup is very, very important and becoming very important for most of the cancers. So this is again another graph which shows a similar thing. So based on the not only on the immunophenotype, but upon the genetic studies also, we need to risk stratify, and the prognosis and the overall outcome depends upon that. Next slide. So this is just a picture, which is actually, this was a paper which actually first showed that T cell has an atypical immunophenotype, that is early T cell precursor ALL. And if you find this kind of a T cell precursor ALL, it should, you should raise an alarm and has to be treated differently, because next slide, because these cannot be cured without transplant. So prognosis prediction with genomic classification has become like a crystal ball now. I would say once the patient comes to the OPD, the parents, they always ask us this question, whether my child is curable or not. And you feel like that you should have a crystal ball in your hand and you should be able to tell the future. But to some extent, I would say now it is possible because of the genomic and the molecular classification. And we can tell who are the children who are more likely to relapse and who are the children who are more likely to have a complete remission with minimal treatment. Next slide. Similarly, with the Wilms tumor, risk stratification depending upon the histological classification is important. And we not only define the treatment prognosis, but we also define the duration of the treatment depending upon the stage and the histological classification of these patients. So all these things are very, very important. And I would like to emphasize again and again that childhood cancer treatment is very protocol-based treatment, which requires a lot of efforts from various multidisciplinary teams, which includes both includes many people, starting from the doctors, from the pathology lab team, from the nursing care, everybody. When they pitch in, then only we are able to have the best results. And everybody has a very important role in improving the childhood care outcomes. Similarly, with the neuroblastoma, again, we have a different risk stratification like stage, age, and classification, Floyd, and histopathological classification, which tell us which neuroblastoma requires high-risk treatment and which requires a low-risk treatment. So many of the low-risk and intermediate, they just can get treated by surgery alone, and they don't require any other treatment. While in the high-risk neuroblastoma, we know even with the bone marrow transplant, we are not able to achieve optimal results. Next slide. Next slide. So better monitoring again is very, very important. Monitoring of the effectiveness of the treatment again tell us where we are heading. Next. So hematological malignancies, we now do minimal residual disease. It means that after giving an induction kind of a chemotherapy, we do the bone marrow again and we see what is the effect of the chemotherapy. Even if in the high risk malignancies, if the minimal residual disease is negligible, we are able to treat them with chemotherapy alone. But even in the standard malignancies, hematological malignancies, if there is a minimal residual disease, they may require upfront bone marrow transplant. And similarly, for the solid tumors, we have PET CT scans, and definitely these kind of monitoring helps us in tailoring the treatment. Why tailoring of treatment is important? Because we want to prevent the late side effects. We don't want to overtreat our children. Next slide. So this is just an example which shows that impact of doing the PET scan in Hodgkin's lymphoma after 2 cycles of ABVD. Those children who are having a PET positive, they have a dismal outcomes as compared to the patients who are having a PET negative. So this clearly shows that if this treatment is given as per the protocol based, we can improve the outcomes by minimizing the therapy and optimally using the chemotherapy as well as radiation. Next slide. So better treatments. Next slide. So now we have immunotherapies like relapse, refractory ALL. Now they are treated by many agents like blinatumomab, inotuzumab, and CAR T cell therapies. In the high-risk neuroblastoma, as I said, there are dismal outcomes, but now we have anti-GD2 therapy, which is now available in India also. And this is helping us in improving the outcomes in these deadly conditions. So targeted therapies like imatinib was the game changer. It changed the treatment and outcome of chronic myeloid leukemia and Ph positive ALL. ETRA changed the treatment of APML. Before these CML and APML patients, when they used to come to our OPD, we knew that these were fatal diseases, but now these are considered as one of the best cancers to have, because we have a very good targeted therapies, and with minimal treatment, this can be cured. Similarly, PD-L1 inhibitors for Hodgkin's lymphoma and many targeted therapies for brain tumors are available now. Next. So this is a poster girl for the CAR T-cell therapy. Many of you must have heard about Emily Whitehead. So this girl actually was suffering from acute leukemia, and she had a relapsed refractory ALL. She, I think, failed 3 or 4 lines of therapy, and there was no hope for it. But then she got a call from the hospital to get enrolled in one of the experimental therapy, which parents took a call, and she was enrolled for that CAR T-cell therapy. At that time, nobody knew that how this therapy will work, whether the child will survive or not, or what kind of side effects the child may have because of this immunotherapy. But fortunately, she survived, and she paved the way for a very important or paradigm shift in the childhood cancer or leukemia treatment, that is CAR T-cell therapy. And she is doing very well, and they have developed a Whitehead Foundation also to support this research in leukemia. Next slide. Similarly, for the high-risk neuroblastoma, the outcomes have improved tremendously with the anti-GD2 therapy. Initially, when we used to say that even after the bone marrow transplant, the survival was less than 50%, but now it is approaching almost up to 70%. Next slide. And best supportive care. I would say nursing care is the most important. It plays an important and crucial part in team efforts in the overall outcome. I have seen in my clinical practice, if there is a good nursing care, many of my patients, they don't get shifted even to ICU. We are able to very well manage them in the ward. With that, the outcome improves, the patient financial burden is less, and definitely I can never emphasize more that how good nursing care is important in the childhood cancer treatment. Similarly, good antibiotics and laboratory services definitely are the part of the wheel to make it a smooth running thing. Next. So the changing scenario is because of the awareness and advocacy, which we are part of it right now. It is our duty and responsibility to increase the awareness among general public, general physicians. There is a JIC efforts are there, and global advocacy is happening. Then diagnostics is very important. It is very important to have early referrals, better lab facilities, and easy accessibility. Then better treatment and supportive care, improvement in therapies, immunotherapies, better antibiotics, and better supporting care. And research. Research is again a very important. These protocols which have been developed and which has improved the outcomes in childhood cancer would not have happened without any collaborative efforts and identification of molecular markers and better risk stratification. Next slide. So there are inequities in outcomes which have been emphasized before my talk also, that 80% of the children with cancer survive in high income countries, but only 20% of the children will survive in low and middle income countries. So there is a lot of disparity. Most important thing is to know that now the treatments are available, cure is available. And if we make a collaborative effort, definitely we can save many more lives. So awareness and accessibility are the 2 important pillars in improving the childhood cancer cure rates. Next slide. Just wanted to share this beautiful picture of a patient who received in our hospital the anti-GD2 therapy. This is to emphasize that it almost takes a village to treat a childhood cancer. All these colored papers carry a name of a person who actually helped this child during the course of treatment. It includes the name of all the doctors, nurses, dietitians, physiotherapists, patient assistant, pathologists, interventional radiologists, everybody. So it actually emphasized, and this was very heart-touching for all of us, because they included everybody who was involved in the care in the hospital for this child. And it actually emphasized that it takes a village to treat a child with cancer. And with this, I would like to end my talk, and thank you very much. Thanks.
Thank you so much, Doctor, for that very inspiring and presentation. Thank you so much.
Thank you.
Then thank you also for sparing your time with us. Now, I would like to welcome our next keynote speaker. Dr. Stanley Prakash. He is currently working as a consultant pediatric Hemato oncologist in Aster CMI Hospital at Bengaluru, Karnataka, India. Sir, good afternoon. Welcome.
Thank you. Are you able to hear me?
Yes, sir. Very clear.
Okay. So if you can allow me to share my screen.
Of course.
Yeah. Good afternoon, everyone. So it is a pleasure to come and talk to you today on the role of nurses in childhood cancer. Thank you very much for the opportunity given to me to talk to you today in the day of International Childhood Cancer Day. So Dr. Shweta Bansal has already gone through a lot of things, so I'm not going to take too much time on the basics. So in terms of cancer, we all know that it is an uncontrolled proliferation of abnormal cells. And as you see, the cancer is a genetic disease at a cellular level. So it is not a genetic disease of the whole body, but it is a genetic disease at the cellular level. Because now we know that it is because of certain mutations, the cell escape the normal control of the cell cycle, and they start multiplying indefinitely, and that leads to cancer. And only 2 to 3% of the cases were thought to secondary to inherited genetic condition. And in most of the cases, we will not be able to pinpoint any one particular reason why this particular child has developed cancer. So in cancer, the cells starts accumulating. The cells accumulate for various reasons. One is the rate of cell division increases. So you have more and more cell production. At the same time, you don't lose cells because the cancer cells somehow attain what we call this immortality. So the failure of apoptosis, so they keep on growing, and then as such, the cancer keeps increasing in size. And if you take any tissue, normally the cancer cells will be, lot of cells will be in the phase of multiplication as compared to normal tissues. Say, for example, if you grow a normal cell in a tissue Petri dish, it will just grow in a single layer and it will stop. Whereas in a case of cancer cell, it will keep growing and it will keep accumulating. So thereby not obeying the normal rules of cell multiplication. So it's just to give a basic idea how the cancer cells behave differently. But at the end of the day, the cancer cells are our human cells. So which means the medications which we give for the cancer cells are going to affect the normal cells as well. So the kind of childhood cancers which are very common are leukemias and brain tumors. So almost 1/3 of your childhood cancers will be leukemias, and about 1/4 of all the cancers in children are going to be brain tumors, and rest of the tumors make the rest of the pie. Whereas compared to the adult cancers, the spectrum is very different. So if your lung cancer, breast cancer, and those kind of cancers will take a predominance in an adult cancer. And most of the time, the cancer in adults are very much due to environmental stimulus, whereas most of the cancer in children arise from some mutation in the genes, and they often arise from what we call as a primitive cells or embryonic cells. So I think Dr. Shweta Bansal alluded to this improvement in the cancer outcomes. So as you can see, this is a sort of outcomes in leukemia from less than 10% survival around 1970s. Now we are almost more than 90-95% survival. That is in the Western countries. In India, it is definitely above 80% survival is a reality when good treatment care is given. So that gives an idea about how the cancer care has improved over the years. If this is acute lymphoblastic leukemia, you look at all the other cancers in children, it is quite heartening to see that the outcomes have improved in many of the cancers in children. And this is a German data, but you can see that almost 70% survival in majority of the cancers in children compared to where we were in sort of 1960s and 70s. So this improvement has not happened out of fluke. there has been, Dr. Sweta has sort of gone through this already, so I'm not going to spend too much time. So by knowing the cancer well and sort of monitoring the treatment response and targeting the treatment appropriately, we are able to improve the cancer survival significantly. And it also has been helped by many of the national and international cooperative groups, which have done a methodical research to improve the outcomes. Actually, childhood cancer is one field where the pediatric setting sort of leading the adult setting, because in most of the other situations, most of the drugs are not allowed in children before they are tested in adults. So most of the time, the pediatrics will be sort of borrowing things from the adult research. Whereas because the childhood cancer is different and it is rare, it resulted in people cooperating together and doing large-scale studies to improve the outcomes significantly. And another factor which has improved the outcome is the good supportive care, which when I say supportive care, it is managing the complications after giving the treatment for these children. And it is the cancer care is always a multidisciplinary teamwork, so which has been already mentioned. And then the nurses form one of the important pillars of this multidisciplinary teamwork. So with that background, I will come to what is the role of nurses in cancer care. Say, for example, when you look at the role of nurses in overall in the medicine, sort of recording the medical history, collaborating with the teams, administration of medications, doing diagnostic tests, physical examination, providing support to the advice and to the patients, operating medical equipments and educating the patients, providing basic bedside care and advocating for the patients and maintaining inventory and training the staff as well. So these are all the sort of general roles which is accepted as the normal nursing roles. How is it different in pediatric oncology? In addition to these, there are certain emphasis on certain parts of your work. And so I will divide them into technical skills and sort of generic skills. So in terms of technical skills, central line care is one of the very important aspects of cancer care, and administration of chemotherapy, recognizing a sick child, and awareness about the pediatric oncological emergencies. So these are important skills a pediatric oncology nurse should have and should develop. And that this should be part and parcel of being a nurse looking after childhood cancer. So when I talk about central venous catheters, these are central venous access devices. There are various different types of devices which are placed in children. As you all know, children have got very small veins. It is often difficult to find the veins. And most of the chemotherapy medications has to be given in good veins. And if they extravasate, they can cause problems. And also, because the children will need multiple blood tests repeatedly, and you will need to give chemotherapy, blood products. So the IV access is not something which we can manage on a daily basis by doing IV cannulas, because all the veins will be gone in the first 10 days. And then it will become very, very difficult to manage. So the central line is part and parcel of the cancer care. So we have got different types of lines. So that is what you see there is the Hickman line, so which enters the chest and then goes under the skin up to the neck, where it will get into the bigger vein. So the advantage of having such lines is that all the blood tests can be done by drawing the sample through these, and we can give medicines through this. So it is very, very useful. And also it is not painful. Once the line is in, even though you need a surgery to put these lines in, once the line is in, we don't have to keep pricking the child. So which is a boon in terms of managing the small children where there is multiple interventions are needed all the time. So the main people who will be handling the central lines are the nurses. So this is a Hickman line, which I was talking about. That is a line outside, and this is which is inside the patient. So you can see that most of the line is inside the patient, and what you see outside under the dressing, and then so the tube which is outside, which can be used for sort of taking the blood samples and giving medications. And Chemo Port is the other type of device which is inserted in children and adults. So as you can see, the diagram on your right hand side is how it will look after it is inserted when the needle is not in place. So the patient, the child can do whatever they want, take bath normally, can even go for swimming, because it is under the skin. But whenever you need the access, there is a special needle, which you can see it on the diagram on the left-hand side, which you can insert it in the chemo port at the center, because the backside of is quite thick metal or plastic, so it will not go and enter into the body. So every time you access the needle, you are in the vein. So that is quite useful to manage, especially in younger children. Chemo ports are very, very useful. And this is the PICC line, where this is a peripherally inserted central line, which goes through the small vein in the hand, but it goes very far and close to the heart. So the reason for talking about this is very, very important, because say, for example, an ALL, acute lymphoblastic leukemia, the treatment will go on for three and a half years nearly. In that time, maybe there may be about 1,000 times people will go in and out of the central line. So I keep telling our nurses, only one nurse has to make mistake once and contaminate the line for the line to get infected. When it is well managed, these lines will last the entire treatment. So we have to treat it as an extension of the body. So it has to be done like a surgical procedure, and often the pediatric oncology nurses are the ones who will be dealing with this line and providing excellent care. And next part of the skill set is the administration of chemotherapy. So what is the difference between the chemotherapy and a normal medication, say antibiotic? So like I said earlier, say for example, a bacterial cell is very different from a human cell. So you can design medications to kill the bacteria, but not to touch the human cell. Whereas cancer cell has come from a human cell. So whatever the medicines you design, it is going to partially affect your normal cells. So that is why you develop a lot of side effects when you give chemotherapy, but there is no other go. So there are more and more targeted therapies coming on board, but still chemotherapy forms the backbone of treating any childhood cancer. So which means that there is going to be a lot of side effects. And I tell to our nurses, chemotherapy is like a poison. The poison which saves life if you give it at the right amount, right way, and the right method. If you give less of a poison, the cancer is going to come back. If you give more of a poison, that is going to kill the patient. So you have got a very, very small margin within which we have to operate, and there is no room for error. So that is very, very important. So anybody who is handling the chemotherapy has to be highly skilled and will be very, very methodical, and the dose calculation, recalculation, and how you dilute it and how you put up the chemotherapy is very, very important. And the chemotherapy specifically targets all the fast dividing cells in the body. Of course, the cancer cells are fast dividing, and that is the reason why we are giving those medicines. But at the same time, there are other cells in the body which are fast dividing as well, which will include your bone marrow cells. So that is why after giving the chemotherapy, the patients will drop their hemoglobin, drop their platelets, and drop their white cell count. So they may need blood transfusion, they may need platelet transfusion. And if the white cell counts go down, they will develop fever, which has to be treated aggressively. I will come to that in a bit later. And I have already mentioned about the narrow therapeutic window. And also the other fast dividing cells in our body are the hair cells. So which means the patients who are on chemotherapy often lose their hair, and but it will grow back after the treatment is over. And all the mucous membranous lining in the body, they are also fast dividing cells, and because of that, the patients will develop or can develop ulcers after the chemotherapy, especially if it is a strong chemotherapy, which can be sometimes painful. So we will have to manage those side effects after the chemotherapy is given. So when we give chemotherapy, basically what we are trying to do is that we are trying to kill the cancer cells, but chemotherapy often comes in cycles. The reason why it comes in cycles is that we are giving chemotherapy to attack the cancer, but it will affect the normal cells as well as the cancer cells. But fortunately, the normal cells will recover faster, and the cancer cells will take a longer time to recover. So before the cancer recovers, but after the normal cells have recovered, you give next course of chemotherapy. So by repeating the cycle repeatedly, you can bring the tumor burden down to a very low level where you are able to clear the cancer. And the common side effects, which I've already mentioned of the chemotherapy, Some of the side effects are acute side effects, that is during giving the chemotherapy. So that is nausea and vomiting, and the hair loss, mouth ulcers, loose stools, bone marrow suppression. These are all part of the side effects because it affects the rapidly dividing cells in the body. And some of the chemotherapy medications can affect specific organs. For example, cyclophosphamide can cause hemorrhagic cystitis, where you can have bleeding from the bladder and you can see the blood in the urine. And vincristine will affect the nerves, which can cause weakness and pain. And doxorubicin is a drug which can affect the heart in the long run. So these are some things which we will monitor. And the nurse's role is very much important in monitoring the side effects and especially assessing the level of pain and so on and so forth. And why are the children with cancer are more vulnerable for infection? That is because a lot of the defenses are damaged. So we do have natural barriers in our body, which include the mucous membranes, skin, and when you give chemotherapy, as I already said, that the ulcers are going to develop. So your normal barriers are damaged. In the normal circumstances, if a bacteria happens to enter in your body, you have a lot of bacteria within yourself, in the gut, in the mouth, in the skin. So normally, if the bacteria even manages to enter into the body, your white cells will attack them and clear them. So that is one of the main function of the neutrophils. But in the chemotherapy, you are not only damaged the mucosal barrier, but you have also damaged the white cells, and there are no white cells to fight. So the bacteria are free to enter, and they can enter into the bloodstream and can make the patient really, really sick very quickly. And in addition, you have got central venous catheters, which can, if not handled properly, they can also act as a source of infection. And overall, because of the chemotherapy, your immune system, your immune memory, everything is quite badly affected. So the cancer patients are very, very vulnerable for various infections. And one of the important pillars of supportive care is recognizing these infections early and treating them very, very aggressively till the patient improves. So recognizing a sick child is a very, very important part of being a pediatric oncological nurse. So one of the things which I keep reminding everybody is that what we call as a disproportionate tachycardia. So that is one of the early signs which is almost quite reliable in terms of picking up very sick children. Obviously, the heart rate can increase for various reasons, pain, anxiety, so many other reasons. But if the heart rate is consistently going high in spite of the child not having fever, or if the child is having fever, the heart rate is significantly higher than what you would expect for that degree of fever. And then that is one of the early signs we should be able to recognize and able to pick it up and warn very early. And poor circulation should be able to pick it up. And there are a lot of early warning tools which the nurses use where you can pick up abnormalities very early on. It is not only the actual score which is important, but it is more of the trend which is more important, because we have to pick up a deteriorating child very early in the setting of pediatric cancer treatment, or any cancer treatment for that matter, because they don't give you time. So whereas a normal patient who gets an infection, they can have fever for 2 days, 3 days, and then they go to the doctor gives try some medicines, and then they do the blood test. So it all goes in a very slow motion, which is completely fine if your immune system is normal. Whereas a patient who is immunocompromised, they can have a fever in the morning, deteriorate very badly in the evening, and maybe dead by the next day. So that is why the fever is very, very important sign in cancer patients. So one of the things which is very, very important and very aggressively managed is what we call as a febrile neutropenia. So that is fever more than 38 degrees. And if the neutrophil count is less than 500, it has to be treated as a medical emergency. It doesn't matter how the patient looks, and you cannot assess just by looking at the patient. When people earlier times, before the things were very streamlined and protocolized, when people were just deciding whether to give antibiotics or not in this kind of setting, mortality was about 20%. After the how we approach these patients has changed. Now everybody who comes with a fever, after chemotherapy, when the neutrophil count is low, you take the cultures and start antibiotics straight away. So with this kind of aggressive treatment, the mortality has gone down to sort of 0.5%. And there are other emergencies which can happen in the pediatric hematology oncology setting. One is severe sepsis and septic shock, tumor lysis syndrome, where at the start of the treatment, especially when a high white cell count, leukemia and things like that, when we start the treatment, a lot of cells will break down and a lot of the electrolytes within the cell will get released. So you can quickly develop a very high potassium, very high phosphate, low calcium, and renal failure, which we call as a tumor lysis syndrome. The way we manage this is running a very high amount of fluids and using some special medications. And also when there is a very high white cell count, they can go and clog the blood vessels in the brain or lung, and that can cause severe problems. Sometimes because of the pressure effect of the tumors, especially if it is in the thorax, it can press on the windpipe, making it difficult to breathe or affect the venous return, when we call it a superior vena cava syndrome, or a tumor compressing on the spinal cord, which if it is not addressed very quickly, it can cause permanent damage and paraplegia. And the infections can also lead to hypoxemia, or sudden lung failure, or sometimes strokes and other things can happen. Seizures can happen with the cancer patients. So these are all the some of the hematological emergencies, oncological emergencies, which we may have to deal with it, and the pediatric oncology nurses has to be well versed with it. And the role of nurses in pediatric oncology in terms of generic skills, one of the most important thing is the communication skills. As already been highlighted, the pediatric oncology is a multidisciplinary teamwork. So every part of the team has to communicate with every other part. We cannot work in silos, which will lead to damage to the patient. So communication skill is one of the very, very important skill in terms of looking after the patients, and we have to ensure the patient safety, teaching and teamwork. So in terms of patient safety, it is important to give the right medication at the right time. So often you would have heard about this Swiss cheese pattern. Normally before a harm is done to the patient, there has been several mistakes. It is usually not one mistake. It is more than one mistake, and unfortunately all fall in line. Many of the times some mistake will happen, a corrective action will be taken, and then it doesn't reach the patient. So one of the important aspect of anybody who is dealing with highly risky areas like cancer treatment is to make sure that if any small mistake happens, it has to be reported, investigated, and corrected. And what is very, very important in this not to start blaming people. Because when you start blaming people, the next thing that is going to happen is that all the mistakes are hidden under the carpet, and then finally one big mistake will happen. So it is very, very important. Any mistake we have to practice a very open culture. So in that, the entire team has to be communicating well with each other, and every small mistake has to be discussed open without blame, and try to fix the system so that such things doesn't happen again in the future. And also the assessment and monitoring is another important aspect which the nurses do. So everybody knows the vital charts, and you record the heart rate, respiratory rate, temperature, and saturations. But what is important is not just recording them. It is actually interpreting them, and also picking up things when things are going wrong, when picking up early and escalating and addressing is what is very, very important. When the child is really, really sick, everybody will know that the child is sick. There is no point in picking up cancer patients when they're really, really unwell, because at the time they end up in a PICU or something, and then whatever the efforts we put, the outcome may not be great. When things are picked up very, very early and addressed, it makes an enormous difference in terms of final outcomes and survival. So a lot of the improvements have taken place in these areas where the problems are detected very early and addressed very early. And assessment of the IV line site and dressing and making sure that there is no line site infections and things are important. And also assessment of the mental status and pain and intake output is very, very important, because one of the earliest sign of patient going into severe sepsis would be reduced urine output or development of edema in the body as the capillary leak increases. And communication skills, as I have already highlighted, so communication skills not only within the team, with the family, because the oncology nurses are the people who are going to be with the family more time than the doctors. So when I used to work in the UK, we always used to ask the nurses because they give all the information about the family, what is the interaction between the family, how they are taking care of the children, how is the child is doing, whether they are happy with the service or not, everything. So the nurses know most of the time in these areas much more than the doctors do. And that is how it should be. And within the nursing team, the communication has to be quite good so that the handover of the jobs, tasks remaining, what needs to be done, what is expected, everything has to be very clearly defined. And whenever, a lot of these patients will have many procedures and things done. Nurses play a very, very important role in coordinating all these things, and they will have to communicate with other departments and other members of the multidisciplinary team. And it goes on in a constant basis. So that is very, very important skill to be a pediatric oncology nurse. And then the role in teaching. So it is not only the teaching the other nurses who are newly coming and joining the service, but also making sure that the family understands everything, because they do spend a lot of time. Sometimes they will direct the questions to the nurses, and then they will have to address it, or if they don't know, they have to escalate it to the more senior person, so that the whole team performs very well. And it is important to keep the knowledge and skills up to date all the time, because it is rapidly evolving and developing all the time, and we continue to learn throughout our careers. And the role in working as a team member, because this is a very complicated care. Multiple inputs are needed. Nobody is more important or less important. And so constant communication is what is very, very important in providing the best care. Otherwise, mistakes will happen more often. And we have to be aware of our own emotional needs and colleagues' emotional needs, and ask for help if something is not clear. Never try to do something if you are not sure about what you are doing, because always there is help around. And providing emotional support to the family is very important as well. And you need to take care of your own emotional needs as well. So most important aspect of the pediatric oncology nursing is being a patient advocate. The nurses always have to be the advocate for the patient. And especially our younger patients, they themselves cannot talk. So the nurses sometimes are very vocal in terms of what the patient wants. And actually, I would really prefer such nurses, because they have to act in the best interest of the patients. And so pediatric oncology as such is a demanding field, but it's a very rewarding field, because what we have to understand is every single one of the patients whom you treated survived is a credit, because we have saved a life. Not many fields can say that. And so and also the patients become very and also they almost like a bond, because you spend a difficult time with the patient. So the whole team, the patient will remember them forever. So whenever they get cured and come back, they always come and thank all the doctors, nurses, and every bit of the team, because they appreciate what has gone through and how much support they got from the team. So they are really genuinely valued by the patient's family and the multidisciplinary team. Thank you very much for the opportunity. So I'm happy to answer any questions if anybody has any.
Thank you so much, Doctor, for your presentation. I have a few questions here, if you may.
Sure.
Let me call on Arijit Malik. You were raising your hand earlier. Do you have any questions? Arijit Malik.
No, ma'am, it's good.
Okay. All right. There's a question from Dr. Uma Maheshwari. If time permits, can you please clarify the reason for new cases? And also, is there any strong evidence lifestyle-based cancer is more nowadays?
Sorry, can you repeat the question? I didn't understand it very well.
It's from the chat, from Uma Maheshwari. The question is, if time permits, can you please clarify the reason for new cases? I think it referring to cancer. Then
Okay, so
go ahead.
right. So that there is a possibility, but there is no confirmation that the cancer incidence is increasing. It is possible because now more patients are being diagnosed with cancer because our diagnostics has improved. We are picking up more cases. And as I said, environmentally, is there any particular reason why the cancer will increase? So far, obviously, there are factors which will increase the risk of cancer. For example, excessive exposure to radiation, excessive exposure to carcinogens. So these kind of things will increase the risk of cancer. But in any given individual, often we cannot find a factor which has increased the risk of cancer. So I have explained before, the cancer happens because of some mutations which has happened in the cell. So every cell has got a lot of genetic information which has to be copied whenever the cell divides. Sometimes it is like a spelling mistake. You copy from one to the other, you get a mistake. And lucky for us, majority of the mistakes are in a place which is not important. So for example, if I test all my genes in our body, in my body, in every cell, I am sure there will be some mistakes, but nothing has happened because that mistakes was not in a place which are very important. Rarely, some mistake can happen in a place which will control the cell multiplication, in the genes which control the cell multiplication. When that happens, especially not one mutation, it is more than one mutation, then the cells go out of control and they start dividing on their own. And that is when cancer happens. So to answer the question, I think I hope I have answered your question. So most of the time, there is no particular reason. If you ask why this child developed a cancer, and if I gone through the history, there is nothing to say. It is just bad luck. Somebody would have developed a cancer. This child had developed a cancer now. So now we have to deal with it. That is the bottom line.
Thank you so much, Doctor. Here's another question from Rambabu PD. Any study on COVID impact over childhood cancer?
COVID impact on childhood cancer.
Yes. Are there any studies recently?
There are a lot of studies. I mean, I don't think there is any evidence to say COVID increases the risk of childhood cancer, but COVID does affect the delivery of the care, because in many situations, when the COVID first wave came, second wave came, everybody was scared of COVID, and people delayed coming to the hospital because of that. So the cancer got diagnosed late. And some people, even during the febrile neutropenia, they did not turn up to the hospital in time because they were worried about COVID, whereas the febrile neutropenia is far, far more dangerous. And also in the hospital logistics, there were problems because the wards were shut and part of the hospital became COVID, and then we were shifted to some other place, and those kind of things. So a lot of practical difficulties happened because of the COVID. But I think now because now we have got now we know more about the COVID, now things have got more streamlined.
Mm-hmm. Okay. And if you may, we still have a few more questions here, Doctor.
Yeah, sure, fine, yes.
From CPT Rachel U, after giving the complete cycle of chemotherapy, is stem cell therapy advised?
Sorry, say that again.
After giving the complete cycle of chemotherapy,
yes,
is stem cell therapy advised?
Right. Okay. So stem cell therapy is a type of treatment where you are removing the patient's own bone marrow and then giving new stem cells to the patient. It is not advised in every condition. So certain situations, we will need stem cell treatment. For example, leukemia is a cancer of blood. Majority of the patients with leukemia, they won't need a stem cell transplant. They will get cured with chemotherapy alone. But a proportion of the patient, either the leukemia will come back or the leukemia doesn't respond to treatment. In those kind of scenarios, or they have got certain high-risk mutation, what we call as high-risk mutation. So we know even before the treatment starts, we know that this patient is not going to do well if you just give chemotherapy. So in that kind of scenario is when you will go for a stem cell transplant. So the when if there is an indication, say relapsed leukemia, certain types of leukemia, then you have to use chemotherapy because you have to use stem cell transplant because it acts in a different method. So one of the method it acts is what we call as a graft versus leukemia effect, because the stem cells come from another person and the new white cells has come from the other person. Now you have changed the immune system. So the immune system is now that of a donor. So the donor immune system will keep attacking the cancer and prevent it from coming back. And that is what we call as a graft versus leukemia effect. So that is why we do the stem cell transplant, because chemotherapy, still you have got your own immune system all the time. Whereas when you give a stem cell transplant, you are giving not only you are giving high medications to remove the cancer, but you are also giving a new immune system. And that is how it works. But it doesn't have any connection with the COVID. I mean, even whether COVID is present or not, especially during the COVID, you will not do a stem cell transplant. You will just delay it by 2 weeks or so. So it doesn't really make a big difference.
Thank you so much, Doctor. And I still have 4 more questions.
Right.
How can we manage anticipatory emesis in children undergoing chemotherapy in general?
Okay, excellent. So that is a very good question. So chemotherapy induces vomiting. A lot of the chemotherapy medications cause vomiting. And so we give medications to control the vomiting. So one of the common medicines which is used is ondansetron, which we give to prevent, so that sort of calms down the center in the brain, which stimulates the vomiting. So the question is about anticipatory vomiting. So sometimes what happens is that after the child has experienced chemotherapy, especially if that episode was bad, then it psychologically affects them and the brain remembers it. So next time when they come for chemotherapy, even before you put the first injection, even if you hanged the chemotherapy, just by being in the ward, that causes a lot of vomiting. So it is more of a psychological phenomenon. So what we do for that is, one is to make sure such patients, we put plenty of medications so that at least the next cycle, they don't have a lot of vomiting, so that the following cycle will not be too much of a problem. And also they will need some psychological support, some distraction treatment, so that they are not constantly thinking of, I'm going to vomit, because that kind of thinking and psychological situation will bring its own vomiting again. So that is how we deal with it.
Thank you so much, Doctor. And 3 more questions.
Yeah.
Any study on hemolytic anemias pre-malignant?
Sorry, hemolytic anemia being pre-malignant.
Yeah, any study?
Okay, so see, hemolytic anemia is a different condition. It is not a cancer.
Okay.
So, basically there may be a genetic defect or some other reason why the blood is breaking down very fast. Some of the genetic hemolytic anemias like thalassemia, sickle cell, we will do a bone marrow transplant for that. And they are generally not pre-malignant condition, but there are some pre-malignant situations where it can manifest as hemolytic anemia. Say, for example, something called myelodysplastic syndrome can present like a little bit like a hemolytic anemia. So it is not. So myelodysplastic syndrome is a pre-malignant condition, but most of the hemolytic anemias are not related to malignancy, even though hemolytic anemia can be a manifestation of a malignancy. But majority of the cases, it is not related to malignancy. It's a different conditions.
All right, thank you so much, Doctor. And 2 more. How to manage tumor Lysis syndrome? Can you clarify, please, sir?
Sorry, what syndrome?
Tumor Lysis syndrome.
Tumor Lysis syndrome. Okay, very good.
Lysis, I'm sorry.
Yes, good. So tumor Lysis syndrome. This is a kind of situation. So I think if you all remember your basic cell physiology, there are certain electrolytes which are high inside the cell. So that is potassium and phosphate are very high in the cell. whereas sodium is very much outside the cell. And when the cells break down, the lot of these electrolytes which are inside the cell will get released outside. So, for example, your potassium level in the blood is between 3.5 to 5.5, but it has to be very, very strictly regulated. If the potassium goes up, it can create arrhythmias and your heart can stop. If the potassium go down also, your heart can stop. So it is a very, very important thing where you have the potassium level is very strictly maintained in your blood. And similarly, phosphate is another thing which is very well controlled. If the phosphate level goes up, your calcium level in the blood will go down because they are inversely related. And if the calcium level goes down, you can develop fits. You can develop something called as a tetany. All those side effects can happen. So in tumor lysis, what happens? You have got a lot of cancer cells. So because the cancer kept increasing in the body, and then we are starting treatment. As we are starting treatment, some of these cancers are very, very sensitive to the medicines which we give to kill the cancer. So now a large number of cells will break down at the same time. When they break down, they release a lot of these electrolytes. The potassium level in the blood will go up. The phosphate level in the blood will go up. And similarly, the calcium level will go down. And because of that, it can put the patient into life-threatening situation. Even though the patient has cancer, you can kill the patient by not controlling this tumor lysis syndrome properly. And also there is another thing called uric acid, which is produced because of the cell breakdown, which can actually cause renal failure as well. So how do we manage the situation? Is that because from the size of the tumor or from the white cell count, we sort of know that these patients are at a very high risk of tumor lysis. So such patients, we will put them on a high amount of IV fluids, almost like 3 liters per meter square per day. We give a large amount of IV fluid, will be running for 24 hours before we start the treatment. That is to wash out any of these electrolytes which come out, so that they will, because of the large amount of fluid, they'll keep on passing urine, and then all these electrolytes will get washed out. And there is another drug called Allopurinol, which the patient will be put on to reduce the production of uric acid, so that the kidneys don't go into failure. So these are some of the precautions we will take before and give this treatment for 24 hours or more, and then start the treatment.
Thank you so much, doctor. And I have last question. Can you put light on immunotherapy?
Yes. So immunotherapy is a sort of upcoming treatment. So what we mean by immunotherapy is that we are using agents which is part of the immune system, basically. So for example, when we talk about chemotherapy, they are chemicals. They are chemicals which are affecting the cells directly. Whereas immunotherapy is where some antibodies or something is made which will attack against a particular target on the cancer cell. For example, B cell leukemia is a cancer. So let us say B cell lymphoma is a cancer of the B cells. So there is a particular antibody which we already have, something called rituximab, which is a monoclonal antibody against the B cells. So while you are giving the chemotherapy, we will also nowadays we also give this rituximab, because it will go and kill all the B cells in the body, which will include the cancer cells. We can manage for some time without the B cells. So even though it will affect our normal B cells, it will significantly reduce the size of the cancer, so that the other cells can sort of reduce. Other chemotherapy agents will work better. So you sort of, it acts along with the chemotherapy. Say for example, if I have to give another example, there is a new drug called belantamab. So belantamab, which is a drug which is called a bispecific engager. So it is a very, very clever drug. So what, because as you know, the immunoglobulin is like Y-shaped. So the ends will attach to different antigens. So in this one Y will attach to the B cell, and another Y arm will attach to the T cell. Basically what it does is it brings the B cells and T cells together. One of the job of the T cells is to find out which are all the abnormal cells and kill them. So by bringing the T cells next to the cancer cell, it will actually kill the cancer cells. So these are examples of what we call as an immunotherapy. And there are further example, more sophisticated one is something called as a CAR T cell, which Dr. Shweta Bansal briefly alluded to. So the CAR T cell is a T cell which is engineered to recognize the cancer cell. So it is your own, what they do, they take your own T cell and then they genetically manipulate the T cell, because the T cell will attach to its target with an receptor. So you change the receptor to say that you change the receptor to recognize the cancer cell. And then you put the cell back into the body. So then what the T cell goes, it goes everywhere and sort of looks at, so whenever it can see its target, it will attach and kill it. So thereby it will kill the cancer cell. So that picture which was put up of the first patient which used the CAR T cell therapy and survived.
Thank you so much, Doctor.
Yeah.
Thank you so much. And is it okay? We still have 2 more questions.
Okay. Yeah. Proceed.
Okay. Fungal infection of brain. It is a side effect of proliferation of cell.
Okay. So fungal infection of a brain is a different type of infection. So you can broadly classify the infections into 3 groups. One is bacterial infection, which we all know, very common. And when we talk about the febrile neutropenia, we are mainly thinking about the bacterial infection. And viral infection, and you know that there are a lot of different viruses, including dengue, COVID, they are all viral infections. And the third type of infection is the fungal infection. Fungal infection is due to the fungus, which is a different type of organisms. But most of the normal people will not develop fungal infection because their immune system is good. Whereas people with the poor immune system can develop fungal infections, which include the cancer patients. So the fungal infections can happen anywhere in the body. Most of the time it happens in the lungs, or it can happen in the kidney, liver. Sometimes it can happen in the brain also. So when the fungal infection happens, it is often very, very difficult to treat because they don't respond well to the medications. Even though there are medications, you need a prolonged treatment and the treatment becomes very, very expensive because the medications are very costly as well. So that is the major problem. And also, if the cancer has not gone away, then because you have to give chemotherapy, so you will again bring the immune system down. So you won't be able to eradicate the fungus very well. So that is a problem. So fungal infection is a very serious infection. If the brain fungal infection happens, it is very, very serious. It can be life-threatening. Sometimes you may need even surgery to remove the fungus and then continue with the treatment.
chat में IAOs.
I'm sorry. All right. Doctor, last question.
Yeah.
How do we manage family who opt both treatment, chemotherapy and alternative therapy?
Sorry, repeat the question again.
How do we manage families who opted both treatment, both chemotherapy and alternative therapy?
Okay. So in terms of treatment for cancer, there are different types of treatments, but they are not exclusive to each other. So some solid tumors, you need surgery. That may be the main part of the treatment. The other treatment is a kind of a supportive role. So then you have got chemotherapy and you have got radiotherapy. So most of the time, depending on the type of cancer, you may just need chemotherapy, or you may need all the 3 chemotherapies, surgery and radiotherapy. Or some cancers, rarely you may need just surgery. And some cancers, it depends. So most of the time, when the cancer is diagnosed, we do all the initial investigation, staging and everything, and then we decide what is the treatment protocol, which will specify at the start of the treatment, what are the things we are going to do. It is going to be chemotherapy alone, or if it's only chemotherapy, how many cycles, whether it's surgery, radiotherapy, at what time these things will be done, and all those things. So this is the overall cancer care. Okay. So when you talk about alternative therapy, I assume it is non-allopathic type of treatment. So in majority of the cases, as far as cancer is concerned, I don't think there is a big non-allopathic treatment which is going to cure the patient, at least as far as I am concerned. And anyway, I am not an expert to comment on those areas. But I would say, if you want to cure the cancer, the best proven method is the allopathic treatment, which you have seen the graphs and things like that, how the cancer survival has improved. Whereas 50 years ago, almost everybody died if they developed cancer.
Thank you so much, doctor, for catering all of the questions. And one more, doc, is MRI scan needed in childhood cancer?
No, it again depends on the type of cancer. Say, for example, if you have an abdominal mass, you will need an MRI scan. If you are suspecting a brain tumor, you will need an MRI scan. But if you are thinking of leukemia, we don't do an MRI scan. We just need to do a bone marrow test and confirm the diagnosis. So it all depends on the type of cancer, whether we will need an MRI scan or not.
Thank you so much. Thank you so much, doctor, for answering all the questions. And thank you all for the participants that are very interactive in our session today. And thank you so much, Dr. Stalin, for your time. And now, on behalf of the IAO Association, I heartily thank all the delegates and students who have joined us today, which is very active and interactive. Thank you so much. Thank you all for participating in our webinar today. Stay tuned with us for more updates regarding the IAO webinar and conferences. You can download your e-certificate in our IAO dashboard. Right? Thank you so much, everyone. This is your host, Jojo Mehoy. Have a great afternoon. Have a great evening. Good day, everyone. Bye-bye.